I'm just very grateful to be here today. It is like coming home. I spent some time here in 1991 and 1992 when Carl Anderson, I believe, was the dean here. And I think even though with the renovations, we're in a different building, we used to be in the Dominican House of Studies at the time, I still see that there's plenty of graffiti on the tables in front of you. So. This is a real challenging topic for myself because I've been in both camps. So I come to you today as somebody who delivers babies much better than I give talks. I'm a practicing OBGYN, and I've been on both sides of this issue. Going to Mass this morning, that gospel reading from John 7, they're not really sure who Jesus is. And it's this division of people over who Jesus Christ is. And we find Nicodemus, who in a few chapters earlier comes to know Jesus Christ, and he sees beyond the surface and kind of begins to see that this guy is the real deal. That's the problem that we're facing right now in healthcare, especially for Catholic healthcare. Who is Jesus Christ? What's the deeper meaning of the human person? And so even though I fell in love with my wife about 4 years before I came to the JP2, I fell in love with her eyes, right? Those beautiful blue-green eyes, the windows into the soul. I learned here in this institute how to love the patient, how to see the dignity in the human person. I learned it as part of my academic career here. Father Gus de Noia, who's now gone on to bigger and better things, Father Benedict Ashley. These men and women challenged us to the core of our being to be the best of who we are. And so when I had my conversion, going from being in the slop, terminating babies that were 2 and 3 pounds, helping work with embryo, creating, sucking eggs for in vitro at the Jones Institute as a first and second year resident in 1987 and 88. My wife and I started the Tepeyac Family Center, where we wanted to do the best of modern medicine with the healing presence of Jesus Christ. Nothing less. Coming out of the Basilica today, that universal call to holiness, not a joke. In fact, it's more real than the Affordable Care Act is today, even though I am speaking in Washington, D.C. So this idea of these principles, initially the principles were practice excellent medicine, see the poor in your daily work, and follow the teachings of my son's church. That's what the Mother of God said. But we've developed it into trying to adapt it. Health is based on relationships found in community. Health. Focus on health. But that you have to go back to in the beginning to find what real health is, right? We keep hearing that over and over. Health is based on relationships. It's coming home here because I see so many friends, people that I've taken care of, people that I've helped deliver their children, people that I've had friendships with. You try to build that relationship between mom and child, so it's that wonder, right? The human person is different than all of creation. Because as Carl says, we can wonder. We look around us. It's wondering about creation. And when I see it, when a mom holds her baby, when a mom holds her baby, when a mom begins to see the ultrasound, you try to create that relationship. Health is based on relationships found in community. Doctor and patient, right? We're talking about that. They don't pick us out of a phone book, but they do. You come in, it's not a 2-minute quick, here's your sore throat, feel the body, mechanistic, here's your prescription. How many times does a woman come into our practice asking for say a yeast infection, and yet she's been stressed about something in the home? The body is integrated, body, soul, and spirit. Health is based on relationships. Medicine is an act of mercy. It's like housing the homeless, clothing the naked. It's not a political football. You can't be both liberal and conservative, left or right. It is the theology of the body, it is the gospel of life, and it is social justice. It's both and. And that's what we're trying to do at TEPIAC. And so this is a kind of a Freedom of Information Act. I usually speak to medical school students where the 300 or 200 people that I speak with don't really see eye to eye with me, because I used to abort babies and I use language that they can hear. And so many people come to those talks and we try dialogue. I can't throw stones. I cannot throw stones because I am the face of modern medicine. I am, because I've been on both sides. And when the Holy Father talks about mercy, when John Paul talks about mercy in medicine, it's incredibly life-giving. And so what I want to focus on in the next just few minutes, I've got about 20, 30 minutes total, is that I want to get to 3 questions that we give. But I want you to understand that the pain of infertility is real. For any of us here who have been in that predicament, it's this idea of this relationship, this lost, I'm married, I think I want to have children. Of course, I see myself with children. My sister, 2 days ago in the office, John, my sister has 4 by now. I've been married, I have none. I can't even walk down the aisle with the diapers anymore. Post-traumatic stress. This is real. And we need to engage people at that level and engage them not by hiding the faith, but by engaging them with language that they can understand. 1 in 4 will experience an episode of infertility in their lifetime. People keep arguing. Now remember, IVF and infertility, there's this tension between this is my body, my choice, and this is my body given up for you. That's the tension, and you're going to see it follow in the next 15 minutes of my talk. That's the schizophrenia, right? Here I am, 1 minute, aborting a baby at the university center because it wasn't wanted, and then going next door because that child was welcomed as a gift. I'm trying to save a 23-weeker. Schizophrenic. And yet that's what's underlying healthcare today. And so I'm just trying to help bring you in. This is, once again, folks, I'm not an intellectual here. I'm experiential. Good old Father Bruchalski, he wrote a book that the Jesuits used in my college that helped me, planted a seed called Present and Absence, about phenomenology. So I'm an experiential person. The reason why I stopped aborting babies was because it's disgusting. The blood, the death. In vitro fertilization, you stop it because when you selectively reduce, the needle punctures the heart and you have to inject. It's disgusting. It's physically disgusting. And it begins to make you think. So I'm coming from a very experiential place, so please, all you academics, and I feel like I'm the opening act to like real folks that are coming after me. I mean that. But the experience I learned from Bruchalski in a book in a Jesuit university. So, is infertility increasing? You know, back when I first started, it was 1 in 9 couples. Now they say it's 1 in 5, 1 in 6. People argue about this. There's a debate on this right now. There's greater availability of services. 212 data from the CDC. There are 456 clinics, IVF clinics in this nation. 176,000 cycles were done in 2012. 51,000 live births. 66,000 children. 30%, 28% multiple pregnancy rate. That's going to be part of the narrative through this process. So I learned about this in Norfolk, Virginia at the In Vitro Center. I was there when Jerome Lejeune was arguing the case in Tennessee about the divorced couple. What do you do with those frozen embryos? Because what I want to talk about today is, I'm going to emphasize those 2 points. Frozen embryos and selective reduction. Because I want to use that because this is how we counsel in our office, okay? What's happening is that he coined the term pre-embryo. Why? Because what we found was that when I started at the university, they had 1 psychiatrist for all the patients. We were doing 400 women a cycle, 1,600 women a year back in 1987. We were the home of the first IVF child in this country. So he goes, no, it's not an embryo, and it's not your child. It's something in between. It has a little bit more moral value, but it's not like your baby. He's now come out and written a book called Personhood Revisited, and he's basically abdicated. He said, now personhood, it really happens after the first or second trimester. Because the problem with IVF is that the abortion mentality has entered into fertility care. The idea of wanted versus welcomed. Gift, person versus product. I'm going to talk a little bit about that here. And so what's happening is he coined the term pre-embryo, and it's where Jerome Lejeune, those were our embryos that Jerome Lejeune was talking about. They were ours at EVM, at the Jones Institute. So they're asking him in the questioning, in the deposition. And he says, yes, it's a neurological problem that I'm trying to work on with Down syndrome. And it's a neurological, and we're going to learn to treat, we're going to get those cells, and we're going to look at those cells, and we're going to try to figure out a way to improve the cognition of children with Down syndrome. The question, I trust you can do all that without harming the children. And Jerome, in his beautiful way, oh, well, you just take a few drops of blood and you cultivate the cells, make cultures. We play with the cells. We do not play with the child. Okay? That's what I want to talk. That's setting the stage. So when a woman comes to us at our center, and once again, we do almost 700 deliveries a year. 30% of those are due to underserved people, underserved women. We try to go out of our way. We're nonprofit. We take serving the underserved so seriously that we're trying to do both and, right? It's tough. So when a woman comes and says, I want children, the first question we ask, and this is critical, is that the first question you have to ask before you go any further, because most of the time, these are women who are trying to discern, remember, they're not all Catholic or Christian. They're coming in saying, my desire is to have children. What's the problem? So we approach it from a very integrated point of view, body, soul, and spirit. We're interested in treating the disease, not the desire. It's very important. We want to go after the underlying principles. What's causing the infertility? But part of the question is, and it always comes up, should I go on to a reproductive endocrinologist? And the question is, because I have to be responsible to them, not for them. The question that gets the most play is, are the embryos that they create, are they my children or are they my property? Do I love my embryos or do I own them? That's my question that I ask. Because you got to go to the foundation principles to get going in this. Because once again, remember, it's easy to love those who love you. It's not easy to love those who don't love you. It's easy to tell them about in vitro and all the good success rates when there's a baby sitting next to them, right? The problem is the process of getting to that point. Are your embryos, you and your husband need to talk about this, because I would say, somebody asked, I was talking to somebody today, yeah, it's a problem of education. We don't educate enough, right? This is fascinating, because what's happening, no one even talks about this. Are the embryos loved or owned? Are they wanted or welcomed? Are they people or are they property? The reason why I say this is that once they started doing statistics, they found out that there are almost 400,000 frozen embryos today. They initially thought there was only 100,000. Remember, there are no good statistics on in vitro fertilization, no matter what they say. I'm going to point that to this in a minute. There are so many extra frozen embryos, and 88% of those are used for families, for family building, it's called. 88% from the RAND SART data is for family building. 11,000 of those 398,000 are for research only. 2,000 are for donation, 2% are for donation, 2% are discarded. Only 65% of those survive the thaw. And so what's happening here is that we have a real problem here. There's all these extra embryos because the process of fertility is inefficient. We don't live in the beginning. We live after the beginning. And so therefore the process of conception, of fertility, of fertilization, is very, very inefficient. And my heart goes out to anyone here who suffered a miscarriage. It's an inefficient process. Because we make all these extra embryos to increase, because remember, when I was back at Norfolk, the issues at the time were, one, what do you do? All these clinics were just getting started. We were the longest, the best, we had the best scientists. What we were doing is, you only should be putting back 4 embryos to get 1, because 3 of them will probably be lost in the process. Back then, there were clinics, because of poor science, they were putting in 10, 12, 15 embryos at a clip. 1987, 88, 89, 90. Not that long ago. That's why there was a 50% over quadruple rate back then. But now we've made things better, right? We always do. We always refine our science. And so now the multiplicity rate is about 30%. What do you do with all those extra embryos? So that was the first question. So my first question, and once again, I just pose questions. I don't have answers. The Holy Spirit does that part. We pose questions, try to give a good conversation, and allow the Spirit to work in the lives of our patients. Second question, do you want to spend time with your sick child? Because as soon as they're going to create the embryos, they're going to have to decide, are they healthy? So we talk about pre-implantation genetics. They actually call it now pre-implantation genetic profiling. So even though they don't say that these are your children, they will use the genetic information of that pre-implantation embryo, blastocyst, to tell you what diseases your child's going to have later on in life. The issue of prematurity. Why is that such a big deal? Because it means that the babies are going to be delivered early, right? The average baby, Nick, is what, 40 weeks? Twins, I'm sorry, Nick, I didn't mean to put you on the spot. Nick, twins, 36 weeks. Triplets, 31 weeks. The earlier their delivery, the higher the risk of CP, lung problems, breathing issues, cognitive issues, vision issues. It's all about the designer children being birthed in Sparta. The problem is that only the fit survive. Because not only are there premature issues, and once again, people understand that IVF is the direct cause of the high risk of prematurity. And right now in the Affordable Care Act, prematurity is one of the areas that we are working on per the government specification. But can you imagine? They won't even admit that IVF is causing it. Now, the Affordable Care Act, it doesn't really cover IVF most of the time. There's only 8 states that cover fertility help in their kind of benefit package. So that's been a real big distinction because of its expense. But this question of, do you want to spend time with your sick child? It's the same reason why we started a perinatal hospice at our program, to hospice the sick child in the womb of their mother if it's incompatible with life, rather than terminating the pregnancy. And so now we're going to get to this question of selective reduction, because that's the second part of the question before I talk about how we approach the patient. If you're interested in looking at the insides of the in vitro world, you go to the Washington Post, an article written back in May 30th, 2007 by Lisa Mundy. It's called Too Much to Carry. It's talking about selective reduction. You know, in the world of in vitro, it's feast or famine, right? You're infertile, then we superovulate you, we create all these embryos, we put them back, and now you have twins and triplets. The risk of early delivery is significant for triplets and higher. What was the industry's response? Selectively reduce. That means taking a syringe of potassium chloride and injecting it into one of your triplets or quads or quints and bringing them from a number of 4 down to 2. And now they're talking about bringing twins down to singletons. I just want to read you some phrases. in the next five minutes, and then we'll finish up with how we approach the patient in our practice. The women and their husband were about to turn their triplets into twins in a procedure known as selective reduction. Selective reduction is one of the most unpleasant facts of fertility medicine. Because of the sharp rise in high-risk multiple pregnancies, the industry had to have a response. And yet there's no way to know how many pregnancies achieved by fertility treatment start out as triplets or quads and are quietly reduced to something more manageable. The Center of Disease Control that I quoted those statistics earlier, they don't publish reports on these outcomes. They don't include this because they're of the reluctance to report them. It's a very sensitive topic, says our president of the Assisted Reproductive Technology Society. It's sensitive personally for patients, but also politically for doctors. Mark Evans is the leading provider of this. He's an OBGYN geneticist. He was a pioneer in fetal surgery in the 80s. He now is the #1 provider of selective reduction. And I admire him because he's upfront with what he does. It's a conversation between him, and as I'm reading this, I want you to think about that health is based on relationships found in community. The goal of his practice is the delivery of a healthy baby, and in some cases, this can be achieved by treating a fetus in utero. In some cases, it is achieved by sacrificing a fetus in utero. Rather than risk losing their entire pregnancy, we can decrease that risk, he says. Triplets, he says she had to the patient, so they tell me, the woman said. He says that these are the hands and the fingers and the arms and the hands. He then looks at the baby's neck to see if it's healthy, the nuchal translucency. Nope, they're all healthy, he says, and she begins sobbing. There are no tissues in the room, and the patient spends the rest of the procedure with her hospital gown over her face, so she would not see any more of what is happening. Ladies and gentlemen, that's post-traumatic stress happening right before your very eyes. How many women do I see in my practice who come in for their exam and they've been hurt through violence? They close their eyes, turn their face, they dissociate. Post-traumatic stress here, folks. It's a 2-day process. Evan's now 54, my age, adept practitioner of fetal therapy. He initially was asked, could he do a half abortion? Kill 2 of the 4, so they all could live. These are the questions that we're asking right here. This is the drama that beautiful title of this segment was given. I don't know if it's possible, but I know I would do it. He does CVS. He checks the genetics of the baby's placenta. Because remember, he's got to create a rationale. How do you decide which of the quads or quints to kill? Well, you do it by chromosomal abnormalities. You try to take out those who are sick. Remember the question, do you really want to spend time with your sick child? Secondly, the positioning of the babies. What's the easiest one to get to through the uterus? 3, professional instincts. And then last, it's sex selection. Those are the 4 criteria that we're using. I used to be totally not willing to talk about gender. However, increasingly, people want is the holy grail, the modern idea of 2-child family, 1 boy, 1 girl. He finds that now morally acceptable. Once again, the article goes on and it begins to talk about the sonographer who's helping him do the procedure. I don't particularly like doing the reduction, she said. I find it stressful. The very patient I think, if it was me, what would I do? That's the question we need to keep asking in medicine. From the Christian, Catholic, holistic, integrative perspective. Some of these people try to get pregnant for the past 5 years and pray to God. And now that they are pregnant, they are telling God, you gave me too many. I sometimes feel like we're playing God, and that's very emotionally stressful. It's very a hard procedure because the baby is moving and you are chasing it. That is what is very emotional. When the baby is moving and you are chasing it. Do you still feel emotional, they ask the doctor. We're not losing one, we're saving some. And remember, it's not an abortion. Abortion is emptying the uterus. And once again, I'm not throwing stones at this. I'm just telling you this is where we're at. Giving a lecture at the University of Virginia, the kid comes to me and goes, you're the first doctor that believes that life begins at fertilization that I've met in my training. First doctor? He was a 4th year resident. So once again, I mean, the article goes on and on and on. Evan's thinking has changed. He now goes from twins to singletons. Reduction is not bad for you, he says. Starting out as quintuplets is bad for you. Treat the disease, not the desire. Remember? This is the confusion. This is actually the confusion. And so they talk about this idea of the attachment of mom to child. The complexity of their attachment to the remaining babies is an apt way to put it. I encountered this one day when I was interviewing a mother who had reduced triplets to twins. In some ways, the selective reduction becomes harder to deal with after the babies are born, the mother says. Of course. Why would it not? We are a person. We have a story to tell. And if you think giving all you've got in love is including ending the life of some of your kids that are healthy, that's what we're leaving these women with. This is the walking wounded we keep talking about. They are babies with personalities, and you become attached to them. And you think, I could have ended up with one of these being gone. And the one that is gone could have been one of these. I have had one patient come into my practice who said, Dr. Bruchalski, she was 22 years of age. She goes, I have this recurrent dream. I think my mother's killing me, murdering me. What? Yeah, it's crazy. I don't understand it myself. I'm in my class at George Mason, and there's a biology class. We're learning about life and biology. My mother tells me that I was a product of in vitro. She said that she had over 18 embryos that she had created. Dr. Bruchalski, I feel like I'm on the Titanic. And my mother was the iceberg. This was a 22-year-old who just walked into the office. This is the trauma. This is what's happening in vitro. I wanted to give you some of these stories to kind of get us where we are. My third question is, do you want to treat the disease? And that's about what we do in our approach. We try to take an integrated, holistic approach to the human person. We try to treat the disease. So if it's endometriosis, we go after endometriosis. Tom Hilgers in Omaha, Nebraska, NAPRO technology, totally revolutionized and gave us hope. Look at the whole person. Look at the disease. Cooperate with fertility. Children are not sexually transmitted diseases. Children are, but once again, the Affordable Care Act, right? It's preventive care. This is the real challenge. We got to move people from wanted to welcomed. It's a gift. And so what I want to end here in the next minute and a half to 2 minutes is essentially the glory of the Catholic approach to this incredible problem. I am convinced that after doing this for 22 years, these methods in vitro do not heal the wounds of infertility. They only deepen them further because they alienate the relationship between mother and child. When you want to look at wonder and see that the world is bigger than you, that there's a creator who we are in the image and likeness of, no, you are now the sole arbiter of that life. So this idea, so once again, as I try to think through this, everybody talks about life being a gift, but there's a new logic being introduced into fertility. In fact, it's not being introduced. It has been introduced, and it's been unleashed on the world. And that logic is opposite and opposed to the idea of gift. It's as if Planned Parenthood, I am now, at the time of my life, I want to have a child, I'm going to have children. So I'm deciding that I want to have children. I know, I went through this. My son came home, my oldest son came home from college last night for the weekend. My youngest son just got into college. They both are going to be going to Virginia Military Institute in Virginia. I got cancer after number 2. Metastatic cancer. Chemotherapy. Instead of losing and becoming curly blonde and, buff body, I put on 60 pounds and it was just horrible. But there were no more children. And I still remember the guy asking me, John, we can always suck out some sperm and we can freeze it and we can save it for later. And here I am, Dr. Bruchalski with the Tepeyac Family Center and Divine Mercy Care, and I look at my wife and I go, nah, I don't think we're going to do that. And she's like, nah, I don't think we're going to do that either. But I say that in kind of defense. I wanted as many as God would give me. But I thought that was going to be 5 or 6. It was 2. And wait a second. There's some people out there who have none. There's some people out there who have 11. There are many out there who have those in heaven. It's this idea of lining your wills to the will of God. And I know that this institute teaches us that. But this logic is absolutely antithetical. How do you pick out an IVF clinic? Size of practice, statistics, the pregnancy rate with donor eggs, because remember, that's the best opportunity you have. That's the highest effectiveness rate. Remember, fertility is a messy science. I'm Polish. Making sausage, which my uncles did, they're all butchers, is a messy process. Whether you talk about the beauty, but for some of us who see the beauty in that, a piece of rock is just a piece of rock until Michelangelo got through with it. Words are just words unless Shakespeare, you use the limitations of what the Lord's given you and you use it to broaden and expand, and you become truly free this way. And so this idea of looking at the clinic as a place where they make good loaves of bread. I want to go to Harvest Bread Company because they do a little bit better job than Giant. I'm going to go to Dominion rather than this because I think the statistics are there. IVF disposes us to forget the child is mystery. The child is gift. But this is the further problem that we fight in our clinic, because we see this on the other side when these women come to us and they have frozen embryos, or they have children that miscarried. Parents think of themselves as the sole originators of the new life they beget. They saddle themselves with an unbearable responsibility. How can a mere human guarantee the future happiness of his or her child? There is the real pain in infertility. The key to fruitfulness is the acceptance of the soil in which both parents are rooted, the love of God that sustains their relationship. That's how I want to conclude. Because ultimately, when we practice medicine, we are bringing ourselves and our lives into the world. We have to engage the world. That's what real responsibility is. We have to engage God, and we have to engage the world. So at the Tepeyac Family Center and Divine Mercy Care, it is faith-based. People know it when they come in, when they make phone calls. Why? Because you have to engage the world, and that's what makes you responsible. There's always a responsibility between freedom and responsibility, and work helps us do that. So I just want to encourage you all here at the Institute. You're going to leave here with great knowledge. I encourage you to use language to get it out into the community, and then you're going to serve. And once again, it is a delight to come back to a place where I learned so much. And I thank you for your kind attention, and we'll continue this process. Thank you.